Now let's find out what some of the international and Indian guidelines have to say about continuous antibiotic prophylaxis in children. Now I would divide the CAP, or continuous antibiotic prophylaxis, into following the first UTI, and then I would discuss regarding recurrent UTI without VUR and with VUR, because we need to know in these specific circumstances whether to give continuous antibiotic prophylaxis or not. But if you look at the guidelines, you may not find all of them in most of the guidelines given separately. But I am discussing it separately to bring some clarity into this topic. Urinary tract infection. The NICE guideline in 2017, I think they republished it in 2018, said antibiotic prophylaxis should not routinely be recommended in infants and children following the first UTI. Now, the AAP guideline in 2011 said it is well accepted now that the prophylactic antimicrobials following the first febrile UTI in children 2 to 24 months is not recommended. There was some objection to this by the American Urological Society especially, but they came back and reaffirmed that they hold on to the same view. The antibiotic prophylaxis is recommended for patients with UTI below 1 year of age while awaiting imaging studies. Remember that the Indian Society of Pediatric Nephrology guidelines, which is the ISPN guidelines, was given in 2011, and it is in quite variation with most of the international guidelines. I was under the thought that 2011 is under revision, but listening to some of the webinars in IAP recently, I understand that they hold on to the previous view. The reason why they give a more aggressive management for UTI is they believe that many of the children in India do get antibiotic for even fever, and the first UTI may be missed, and what you see as the first UTI may be the second or third. Therefore, they do advise VUR, they advise VCUG even in after the first episode of UTI below 1 year. And while you wait that imaging studies, they advise to give prophylactic antibiotic. But this also, the practice has changed mostly in the Western countries, where they do the prophylactic, they give antibiotic, and on the 8th day, at the end of the first treatment itself, they do the VCUG without waiting for 1 month to do the investigation. Therefore, students who are appearing for examinations in India should understand that the ISPN guidelines differ significantly with the international guidelines, and most of the examiners would be more tuned to the Indian guideline. There seems to be some difference of opinion even from United States. For example, normally UpToDate echoes the management of AAP, but here UpToDate states that you have to take the cases one by one and then individualize the treatment to a certain extent. For example, it goes on to make the statement, in children who have severe or protracted course of illness, who have high risk for recurrence. Now, febrile seizures are not a high risk of recurrence, but when the parents are apprehensive and you have to take it case by case, they are very worried, or there is prolonged hospitalization in the first UTI, there's a renal abscess, or the child has a single kidney, bladder and bowel dysfunction. This is something which is emphasized by the American Urological Society, and in whom prevention of any recurrence would be desirable, to discuss the risk and potential benefits of antimicrobial prophylaxis with families. You have to read very carefully this. They do not say you have to give, but you have to discuss the pros and cons of giving antibiotic. Though the evidence may be against it, you must still consider it. Therefore, definitely the giving, as I said in the beginning, this continuous antibiotic prophylaxis in UTI is a real gray area. Probably it's not even gray, it comes in all shades of color. Now let's look into continuous antibiotic prophylaxis following recurrent UTI without VUR. And remember that most of the literature is on recurrent UTI with VUR, and there is very few studies on this subject. Both UpToDate and NICE guidelines do say that you have to give, you might consider giving CAP in children with frequent urinary tract infections. Now, but they define it differently. UpToDate states as 3 febrile UTIs in 6 months or 4 UTIs in 1 year, total UTIs in 1 year. Actually, in most of the international guidelines, febrile UTI is taken as a sign of acute pyelonephritis, and urine showing pus but urine culture positive without fever is taken as cystitis with local symptoms only. Now, NICE guideline concurs with it, but does not give a time frame in definition of recurrent UTI. It doesn't say in 6 months or 1 year, and it defines in a very complicated way also. NICE defines recurrent UTI as 2 or more episodes of UTI with acute pyelonephritis, upper urinary tract infection, or 1 episode of UTI with acute pyelonephritis plus 1 or more episodes of cystitis, or 3 episodes of cystitis. In other words, to make it more simple, if you have only cystitis, that is, you have febrile urinary tract infection, which is urine in pus, pain while passing urine, and urine culture positive, you have to have 3 infections, according to NICE, to give antibiotic prophylaxis. But it doesn't say in how many months or years you have to develop it. And so if you have only 2, one of them should be an acute pyelonephritis. And pyelonephritis are usually defined as febrile UTI. But some people would say that only if you have done a DMSA and shown that there is a changes in the kidney, you can label it as UTI. Therefore, definitely frequent UTI is an indication for continuous antibiotic prophylaxis. The AAP is silent on this matter. Not many international guidelines stick their neck out and give a definite recommendation how long to give CAP in children without VUR. I could only find UpToDate make a generalized statement telling that CAP can be discontinued if no infection occurs during the 6-month period of prophylaxis. If infection recurs, resumption of prophylaxis may be warranted. This is when you start for children with recurrent UTI in patients without VUR. Now coming to CAP in children with VUR, the AAP does not make a direct reference to it, but states AAP guidelines recommends that the initial workup of children with the first febrile UTI should consist of renal ultrasound only. Now they go on to say that CAP can be deferred in children with normal renal ultrasound. Since ultrasound does not detect grade 1 to 3 reflux, this translates into no continuous antibiotic prophylaxis for low-grade reflux. Or in other words, in non-dilating vesicular ureteric tract reflex, and AAP does not advise prophylaxis in grade 1 to 3. However, UpToDate controversially advise in all children with non-toilet trained children, regardless of the severity of VUR, all patients with bladder and bowel dysfunction, regardless of the severity of VUR, on all patients with high-grade reflux. But the point here is, since UpToDate also does not advocate BCUG in all patients with the first attack of UTI in non-toilet trained children, it is difficult to understand how all low-grade VUR will be detected for prophylaxis in this population. As we have found out earlier, the Indian Society of Pediatric Nephrology guidelines are more aggressive in the treatment. They give antibiotic prophylaxis for children below 1 year old, even for grade 1 and 2 reflux. Now, this is because they think that they still hold on to the old view that scarring in children below 1 year is more dangerous and more likely to cause renal damage. This is not reflected in any of the international guidelines except the Urological Society guidelines of America. Now they say you give, if grade 1 or 2 reflux, you give up to 1 year and restart antibiotic prophylaxis if breakthrough UTI occurs. And grade 3 and 4, they say give it up to 5 years of age. Consider surgery breakthrough febrile UTIs occur. Beyond 5 years, prophylaxis is continued if there is bowel bladder dysfunction. Now, as I told you already, this is in quite variance with the international guidelines. As per Nelson's Textbook of Pediatrics 21st edition, the AUA, the prophylaxis recommended by UAE in children, that is American Urological Association in children at the greatest risk for VUR related injury, those less than 1 year of age. It's not very clear whether they have said it after the first UTI or those in children with VUR, but it looks like it after the first VUR also, first UTI also. They advise prophylactic antibiotics till they are 1 year of age. Remember the Indian Society of Nephrology guidelines. After the first UTI advises only till the investigations are over. The American Urological Society also recommends in children more than 1 year with grade 1 to grade 4 reflux and bowel bladder dysfunction, and or in patients with renal cortical abnormalities. But you remember that if you want to find out renal cortical abnormalities, you have to do a DMSA scan. Therefore, if you have to follow the American Urological Society guidelines, DMSA scan becomes a must for deciding on CAP. When coming to the question of discontinuation of the CAP in children with vesicular reflux, again I could find some reference only in the up-to-date. When VUR resolves spontaneously or is surgically corrected, which is documented by contrast VCUG or radionuclide cystogram. For this is the time, normally after surgery, you do a VUR, and after, if it is fully corrected, you can stop it, either spontaneously or by surgery. Now, some experts stop prophylactic therapy in children older than 5 to 9 years, even when there is persistent VUR. This is because the chances of recurrent UTI become less as the child grows older. However, the evidence for this practice of stopping without the resolution of the VUR is not there. This is a little gray area, and you don't find much written on this in most of the guidelines. Another thing to note is that asymptomatic bacteriuria in infants and children should not be treated with prophylactic antibiotics. This might look very silly and straightforward, but it is not so, because as per American Academy of Pediatric guidelines, a urinary tract infection is only when you have pus cells in urine. A child with fever, even with fever and urine culture positive, may be having an asymptomatic bacteriuria, and it is chance that you did a urine culture when the child was febrile. Therefore, they insist on having urine with pus cells to make a diagnosis of urinary tract infection. But as per the British guidelines, any child with symptomatic child with urine culture positive is taken as UTI. But whatever it is, an asymptomatic bacteriuria, in which especially when there is no pus cells in urine, you should not take it as a UTI, and you should not treat it with prophylactic antibiotics. I have seen many times this mistake happening. Now let's just have a quick look at the medications given for prophylaxis and as per the ISBN guidelines. The medicines are given once a day. The prophylaxis medicines are given as a single dose. Now, if you are giving trimethoprim is a medicine which is very much advised, is 1 to 2 milligram per kg per day of trimethoprim. The dose is calculated on the base of trimethoprim. It is better to avoid in children in infants and below 3 months because of if there is G6PD deficiency. Even otherwise, there's a risk of causing hyperbilirubinemia. Now, nitrofurantoin is also avoided below 3 months, and the dose is 1 to 2 milligram per kg, and avoided in patients with G6PD deficiency. Not easily available, but it is one drug which is liked by the nephrologist because we don't use it for treatment. At the same time, the chances of it causing resistance, developing resistance, are less. However, this nitrofurantoin causes severe stomach upsets, gastric upsets, and is difficult to tolerate in therapeutic doses, but generally in 1 to 2 milligram per kg it is better tolerated. The second line of drugs like cefixime and ceftriaxone are preferred in infants 3 to 6 months of age and infancy. Now, generally, amoxicillin, ampicillin, and cephalosporins are not generally recommended because of the increased likelihood of resistant organism. However, these agents are used in infants below 2 months of age because sulfonamides, trimethoprim, or nitrofurantoin are associated with serious side effects like hyperbilirubinemia. This might be typically so in places where this G6PD deficiency is rampant. It is not so common in where I practice in South India and Kerala, but in the Gulf as well as in the North India, I've seen G6PD deficiency more common. Therefore, it may not be a medicine which you can use easily. Now, if you below 2 months, actually the drug of choice we normally give is amoxicillin, 10 milligram per kg per day once. Now, one medicine which is very well used here is Cefixime. But if Cefixime is also used in the treatment of urinary tract infection, it's quite effective, but we don't want it to develop resistance. But many times we are forced to give Cefixime because we don't have any alternate medicine which is available. And I looked at the literature. There are very few literature in which Cefixime has been advised as a prophylaxis, but this particular study, in a German study actually, in a German pediatric clinic, gives the doses 2 milligram per kg per body weight. I didn't find the prophylactic dose of Cefixime anywhere else.